Minutes, madam. So
Respected Chair and dear friends, the next few minutes I would like to share with you the results of a small study that we conducted on the incidence, clinical features, and management of silicone oil-induced glaucoma. Silicone oil is used for long-term Tamanite. The duration of Tamanite may vary depending upon the type of oil that you use, the retinal status, and the intraocular pressure. And various studies have shown that the incidence of SOIG varies from 2.2 to 56%. The mechanism of SOIG varies depending upon whether there is an early rise of IOP or a late rise of IOP. The aim of our study was to analyze the incidence, the management options, look at the anatomic and functional outcome of eyes with silicone oil-induced glaucoma, study the effect of silicone oil removal on SOIG, not only the IOP control, but also on whether there were anatomical changes in the vertical cup disc ratio, the RNFL analysis, and field changes. This was a retrospective observational consecutive case series on all patients who underwent surgery at our center between 2010 and 2018, who had about 12 months follow-up duration. And for the purpose of this study, SOIG was defined as a persistently elevated Goldman applanation tonometer of greater than 25 millimeter of mercury at 2 consecutive visits, or a rise of more than 10 millimeter of mercury from the baseline value. We had two groups of patients, those with SOIG and those who were SOIG free. These were the data that we analyzed, and wherever possible, in the patient's visual media and the visual acuity permitted, optic disc evaluation, RNFL analysis, and field changes was done. The incidence of SOIG in our study was about 22.5%. The duration of silicone oil tabanite varied between both the groups. It was more in patients who had raised intraocular pressure. The indication for VR procedure needing silicone oil tabanite was similar in both the groups. The lens status was also similar. 9 patients had undergone prior vitrectomy, 2 with gas tabanite and 7 with silicone oil tabanite, and 18 eyes were prior buccal eyes. Primary silicone oil tabanite was there in 13 eyes. Reinjection was performed in 7 eyes. Prior diagnosis of glaucoma was seen in 6 patients, and the incidence of silicone oil-induced glaucoma was 22.5% in this series. The preoperative IOP range was varied from 1 to 22 millimeter. The final IOP before silicone oil removal or glaucoma surgery varied between 20.1 and 40.9. The deviation from baseline was more in the silicone oil-induced glaucoma group. All the patients were started on anti-glaucoma medications, and it was seen that there was a statistically significant reduction in intraocular pressure in about 64% of our patients. Surgical treatment included either silicone oil removal alone, glaucoma surgery, either glaucoma drainage device implant or cryotherapy, or glaucoma surgery alone followed by silicone oil removal, and there was a statistically significant reduction in IOP pressure and the number of medications that was needed to keep the IOP under control. ADIT device was implanted in 1 patient and Ahmed glaucoma valve in 5. At the time of silicone oil removal, care was taken to take out all the emulsified silicone oil from the anterior chamber. A 3-port vitrectomy ports were started, the posterior segment evaluated, and as much as the silicone oil was present could be removed, and any perisilicone proliferation that was present was also removed. Reviewing a management option, we were able to control the intraocular pressure in 91.3% of our patients. Although anatomical stability could be achieved in all our patients, there was progression of the glaucomatous changes even after silicone removal. These were the 2 patients who had keratopathy. Progression of the vertical cup disc ratio, progression of visual field and RNFL thinning was seen in about 10 eyes, indicating the necessity for long-term follow-up of these patients. Looking at the mechanism of development of glaucoma, it differed between the early onset and the late onset patients. While ocular inflammation was the main cause in early onset, rubeosis iridis in patients who underwent diabetic vitrectomy was the important cause in late onset. There's one such patient who had an ocular inflammation which was treated with aggressive steroid therapy and anti-glaucoma medication with control of intraocular pressure. Thus, to conclude, the incidence of silicone oil-induced glaucoma was 22.6%. Medical therapy reduced the intraocular pressure in 64%. Following silicone oil removal or silicone oil removal plus glaucoma surgery, there was a significant reduction in the intraocular pressure. Visual improvement occurred in about 82% of our patients. However, when the IOP was less than 8 or more than 22, the visual improvement was not very great. Progression of the glaucomatous changes was observed, indicating the necessity to continue follow-up of our patients even after silicone oil removal. These are my references, and I thank you very much for your kind attention.
So very nice paper, ma'am. I just wanted to ask you that you said that you also correlated it with the type of silicone oil that was used. So what was your observation in that?
No, in this study, I had used only 1,000 centistroke silicone oil. So this is basically on patients who underwent a complicated VR procedure with 1,000 centistroke silicone oil tamponade.
So all underwent 1,000 only?
Yeah.
And in the immediate post-op period, did you find any of your patients who were primarily a steroid responder because of which they were having high
Yes.
IOP?
If you go back on my slides, there were 19% of patients who were steroid